So this session was built to be a discussion around AI, and specifically thinking about AI from this translation from theory to practice, theory for real life. And so we structured this session a little bit different than you've seen before. We're going to have 3 presentations, and I'm going to ask presenters to be on time, so that we can show some examples of real life practices or implementations of AI. And then after the session, we're going to be joined by 2 other colleagues that I'll introduce at the time to discuss more broadly about different pathways forward, barriers, funding, or directions around AI applications to real life. So to get started, I'd like to invite Moka Lantum to get us going. Moka Lantum is the co-founder and CEO of CheckUps, and is going to talk to us a little bit about that.
Thank you. Good afternoon. This is really nice to be home here because it's over, I think, 10, 12 years where we started under the SEED program with the innovations in healthcare, and they have seen a growth throughout the last decade. So really, it's nice to be home, but really also an opportunity to kind of share sort of where we are based on the lessons that we've learned. So I'm Moka, the CEO. We're based in Nairobi, and we have operations in Kenya and South Sudan. So I'm going to start with a quick video just to give you a sense of what keeps us awake, right? As far as the global health agenda from our perspective. What you have on your screen here is a video animation. It's a bubble plot. And you could click play, please. And this shows data for 3 years. We started collecting data, and this is representative of over 1 million claims from the market. And you would see in red is the high risk, what we have classified as high risk customers, in blue, medium risk customers, and in green, low risk customers. And right now we are in just August of 2016, and you could just fast track. By 2019, and you could pause, this is what the cost was looking like. We had some patients who had been to the hospital 150 times. In red, you see some folks who literally, those high risk, are at least visiting the hospital 30 times. Those in blue are visiting over 10 times. And then the ones in green are visiting 2 to 3 times in 3 years. And on the y-axis, you'd see people incurring over 20 million shillings worth of claims. So $20,000 of claims. Now, conventionally, we think about this in terms of, oh, these are cancer patients. No, these are chronic patients in red. Most of them, you're talking about hypertension, diabetes. So now think about somebody with hypertension, diabetes in a system that allows them to go 150 times to the hospital. And in the lower end, in green, you have infectious diseases towards this bottom part. So that is the data we have. What do you do? The first thing I'd like to say, looking at using an African analogy here, salt and sugar are white, but they don't taste the same. So if we are designing systems for both ends of the spectrum and assuming we'd have the same outcomes, it'd be quite devastating. Can we go to the slides, please? So the question for us is, what should AI do? Not what can we do, what should AI do for us? Next question, next slide, please. Oh, actually, I can click now. So with this data, what we have been doing for the last 6 years is collecting a lot of claims data, but we're looking at the number of episodes per patient. We're looking at the number of claims per visit. We're looking at the total invoice amount, and we're looking at what you call in payment systems velocity of occurrence. And the velocity of occurrence has a very high predictive value of whether the person will be high risk. And we replicated the same work in South Sudan. So to confirm, you see 2016, 2017, and what 2019 looked like. And this is Africa's youngest economy. We wanted to have 2 economies to look at the effect across in Kenya, which is a very mature health financing market, and South Sudan, which is a nascent health financing market. And we observed both trends. Now, this trend here was associated with the fact that the medical loss ratio in 3 years grew from 36% to 96%, That means outpatient insurance for the private market is not profitable. 32% of the population in the claims or the members are high risk, which literally, if you've done insurance modeling, that means you cannot fund such a population. And we started looking at the trends very quickly here. Medication accounting for 57% of the claims, followed by labs and consultation visits. We thought, well, it was the elderly who were causing the problem. This is a problem that is from childhood to adults. So it's a population-wide problem, both genders involved. And the top culprit is upper respiratory tract infection. And general, followed by general checkups, gastroenteritis, gastritis, and antenatal screening. Those are the top culprits. Now, this data was the most informative data for us, whereby the average claim was 4,213 shillings in Kenya for upper respiratory infection, so about $40 if you round it up, with a standard deviation of $20. That means you have a 1 in 2 chance of overpaying for healthcare by 20%. I'm just going, since I'm running out of time, and the top drivers were antibiotics. So what are we doing with AI? We're using AI to see if we can optimize the claim experience for the members and design a health benefits trading process whereby they can get more value for money per dollar. And we're doing so by cutting out the amount of unnecessary visits and the amount of overpricing on medication, but also overutilization of antibiotics. If we reduce antibiotic consumption for let's say right now it's 85% of URTIs who are prescribed an antibiotic, if we can reduce that by 25%, that is millions of dollars saved in the healthcare system. And that's what we're using AI to do. So we have built an AI-enabled preferred network, which is subscription-based, and you pay and unlock benefits, which allow us to deliver medicines and services to you. We have now done with 14,000 folks, and we're enabling that with financing for farmers, for teachers, to enable them access our health benefits and get medicines delivered. And they're saving 25% or more on medicines and over 16% on labs. Thank you.
Thank you, Moka. This was right on time, so that's great. Now I'm going to invite Joy Bhosai. She's founder and CEO of Pluto Health.
Thanks. Oh, this is great. Thank you, everyone. I'm really happy to be here and excited to learn from all of you later today. And thanks for the session earlier. I'm the founder of Pluto Health. Our name comes from the fact that somebody told us we were shooting for the moon. So we said we would go further. So I'm going to share with you today about what we're doing with data and some cool things. Just to kind of share what we do as a company just for a quick second, and then we'll dive into the 2 AI use cases, is that our company believes that every person has a chance to thrive by connecting them to the right resources at the right time. We currently focus on Medicare and Medicaid populations, specifically in rural or areas where there are no or very little primary care access. So what we do is we connect people to what they need so that they have the best chance of health. We apply data science and marry that with care. So a third of our team are clinical informaticists or data scientists. So what we do within one sitting is get as much information about you as possible, your medical records, your insurance information. We integrate over 20 different social determinants of health data sets, things like, what does your neighborhood look like? Do you live in a food desert or oasis? Things like that. We marry that, analyze it, and then try to understand what you need. So really quick, what we do is we work in 3 big steps, and we'll talk about step 1 and 2 today and how we're applying AI. But the first is we access data. So a lot of it is getting your medical records all over the place and all of the good stuff. And then the second is we bring that together, harmonizing it, deduplicating, and analyzing. And once we do a decent job at that, then we look at your potential care gaps. Things like, are you missing a mammogram? Are you missing your age-appropriate colon cancer screening? Are you missing an immunization? And we also understand if you might be at higher risk of accessing it based off of the other factors. So it's all about putting the patient at the center and figuring out what resources we want to connect them to, whether it's a vaccine, an at-home lab test, or access to clinical research. So the use cases I'll go into today center around leveraging large language models, or LLMs for short. And then the second use case I'll go into is how we integrate AI to meet patients where they are. So in this use case, when we integrate all different kinds of data from medical records or insurance, it's never coded the same way. Every health system is different. How many notes have you seen where the doctor never writes the same way, right? And they integrate that. So what we do is we leverage these large language models, contextualize it, and then understand the other diagnoses that the patient has and integrate that into a care plan for them. So we're merging things from all different kinds of places, extracting it, and then creating a narrative around what the patient may need. It helps us in terms of thinking through truly trying to get a sense of what the patient needs in terms of real-time support, potential care interventions that they need. It allows us to do efficient clinical reviews. So with our partners, we're currently working with like Walmart and Walgreens. It allows them to quickly review the data in real time. And it augments our workforce. So what a doctor or a clinician or pharmacist could do or would take them 20 minutes takes us less than 30 seconds, and then they can confirm. So it really augments the team. And the second use case is that we also have noticed that AI can be applied to accelerate adoption with tools. So in some of the populations we serve, English may not be their primary language. They may be an aging population where they absolutely refuse to download an app, but they'll text with us, things like that. So what we do is we've designed adaptive greetings where it just integrates how you converse with patients and then ask them what they're interested in learning. So not just printing out a full report of all of your care gaps, which you may or may not really care about. If you just want to know what vaccines you're missing, you may not want to know about all the other things all at once. So it's making it digestible for the patient and meaningful. And so our hope is that by engaging meaningfully and applying AI, both in terms of the data analysis, but also understanding how we can accelerate adoption, we can meet patients where they are. So that's what we're all about, and it's been really helpful for us. Thank you.
Thank you, Joy. All right, and for our last spotlight, Wilfred Njagi. Sorry, the CEO and co-founder of Vilgrow Africa.
Thank you. Yeah, it's amazing to come right after innovators because we work with innovators. So Vilgrow Africa is a healthcare incubator and investor established in the year 2015, so about 10 years now. I remember when we were established, we were serving a very nascent global health innovation ecosystem. It was only Duke Innovation in Healthcare and us that were serving that market back then. And even today, only we're a total of 3 healthcare-focused incubators in the continent. So feeling very much at home here at Duke. So what have we been able to achieve? We've had catalytic seed funding where we deploy blended financing. We give grants, combination of grants and equity, and we've been able to get a 10x multiplier effect. So we found that we've deployed about $3 million together with technical assistance, and our companies have gone on to raise $30 million in follow-on funding across 30 countries, as you can see there. Below there, we are funded by Agidius Foundation, Lemerson Foundation, IDRC, USAID, among others. And that's the map of our presence, our footprint. You can see we are very heavy in East Africa region, Kenya, Ethiopia, Uganda, Tanzania. But also you can see how many of the companies we work with are female-led. You can see the pink icon and how many are male-led. We're not where we are supposed to be. We would like to have even a more gender balance in our portfolio. Now looking at sample portfolio and some of them that are using AI, the first company is called MamaOp. Dr. Moka made a very good point about overtreatment with antibiotics in Africa is a real issue, especially for children under 5. So if you bring your child to a clinic in a rural part of Uganda or Tanzania and they are presenting with fever and coughing, automatically the doctor right out of the bat will prescribe an antibiotic. So this overtreatment, I think we'll pay a huge price if we are not we don't curb it early. So what MamaOp is doing, the first company there, they've come up with an AI-enabled smart screening tool that is able to triangulate between the respiratory rate and the lung sounds to actually rule out or screen out the false positives for pneumonia. So the clinician can focus on just the ones that are potentially high risk. The second company is called the Pathology Network. They are, in Kenya, we have about 100 or so pathologists. I think they are just between 100 and I see doctor is agreeing with me from Ministry of Health that it's just about 100 and they all like to live within Nairobi, right? None of them wants to be in a far-flung town. And that means that if you order a biopsy or histology or any other kind of advanced pathology, it will take you 3 weeks to 1 month before you get your results back. So what TPN has done is twofold. One is they've said that the patient, once the sample has been taken, the patient job is done. Before that, it was upon the patient to chase the sample, follow up with the lab, and when you get the results, bring them back to your doctor. So right now, TPN is taking care of that. You just get your sample, you deliver your sample, then they will do the logistics of taking the sample to an advanced lab and then upload the screens online where a pathologist can log in remotely and give a diagnosis. So using AI, they're able to now not only automate and reduce the workload by image classification, being able to quickly classify the images and be able to make it easier to diagnose, but also do a bit of the transcription. I mean, doctors, if you're 100 serving 55 million, those are a lot of notes you're going to be writing. So a bit of that transcription and helping with using Gen AI for that. The third company has nothing to do with AI, because I remember in the morning opening plenary, Dr. Krishna said that algorithms are not going to solve everything. Like, we're not going to solve all healthcare problems with just a piece of algorithm, right? We're going to need supplies. We're going to need equipments. So the third company there is locally manufacturing a medical device in Ethiopia. This is a phototherapy. You can see there, those are phototherapy machines, locally designed. So they own the patents on the design and also locally manufactured, which is a fraction of the cost compared to a GE or one of these other big devices. The other thing is talking about intersection with climate change. This device can work with solar power. It can work with alternate power sources. Then the fourth one is Lorogy. As you can see there, they are an FDA-approved teleradiology platform. And what they do is same problem like the pathology example I gave. We have, for example, in Malawi, 1 per 23,000. Can you imagine? Tunisia. Tunisia, you have the ratio is 1 per 23,000. That is radiologist to population ratio. That's huge. And if you think that's huge, go to Malawi. The data we have shows is like 1 for like 8 million. So it's crazy how these numbers are. In Kenya, I know for sure it's also like 100 radiologists for 55 million people. So using an AI-enabled technology, what they are doing is that these scans coming from sonographers, radiologists, can be uploaded on the cloud so that the radiologist can remotely give the diagnosis. But going a step further, using AI to also computer vision to also be able to narrow down on the accurate diagnosis. They've deployed in Kenya, they're also in Egypt and Saudi Arabia. The fifth one is Isola. Isola is a generative AI personal assistant for neurodivergent kids, mostly, so looking at children who have issues like autism and other neurodivergent conditions. And what that generative AI does is, first of all, it's a chatbot that is very customizable, is able to journey with a patient, specific patient, and give very personalized care in terms of expert vetted content and real-time answers. You know, your child, a child who has autism or any other condition wakes up feeling like this, or they have this situation, the parent can just type into the chat and they will be able to get some real-time answers, including whether they need to actually show up at a clinic. So those are just 5 examples of AI-enabled startups that we work with. And I was told to also say, what is our ask? There's something we tell our innovators all the time. When you're in front, make sure you tell us what you're looking for. So for us, we're looking for collaborators, anyone doing good work in the Global South. We're also looking for funders, but most importantly, academic linkages. We want to be able now to do proper case studies on some of these, empirical studies on some of these use cases, AI and other use cases of health tech technologies that we're working with. So yeah, thank you so much, and looking forward to engaging more. Thank you.
Thank you. You can have a seat. Yes, please. And I want to invite, please, Joy, Moka to come up and assemble the panel. And I also want to ask to join us, please, Jim Murray, founder of the Presidential Precinct, Managing General Partner of Court Squares Ventures, and also Rubayat Khan, Director of Health Programs in Endless Networks. And let's talk a little bit more. I want to start by saying that I love that this is an AI panel that nobody showed a deep learning network. Nobody showed a bunch of algorithms, and this is what we're here for, and that's the discussion. What I want to start this conversation around implementation and implications. And I'll start with you, Rubayat. Why don't you tell us a little bit about Endless Networks, your work, and in your work as an AI health funder, what type of opportunities are you looking for now?
Thank you, Joao. So Endless Network is a relatively new global health funder. So we just started funding last year, only been 18 months in this job. So I still think like an innovator. I have been on the implementer side for over 15 years before this. And so when we look at healthcare from our foundation, we try to start from the problem. And when we try to frame the problem, we look at it from the patient-centered lens. So really looking at it, this morning we were talking a lot about the fragmentation and the silos in global health financing and how that basically translates to programs being fragmented on the ground as well. So one of our core kind of mission as a foundation is to basically promote more integration and integrated services and delivery. So we would look at a new service innovation, but try to integrate that into an existing delivery model. We would look at things like pharmacies as a channel where so many people go for care already and try to kind of embed new solutions into those infrastructures. So we come at AI from that same perspective. We look at it from the perspective of solving those fundamental problems within global health. But when we look at AI, there's a kind of a few buckets that we look at it from. So for example, the first and most obvious bracket, and most of us in the US ecosystem would be familiar with this, we're talking about access, we're talking about efficiency a lot, right? Like we're talking about things like transcription of conversations between doctors and patients, like automatically populating electronic medical records, things of that sort, which of course important, even more important in the US context where costs are so like skyrocketing so much. But in the global health context, I think it's much more about things like access, things like quality, and ultimately kind of a disruption of public health itself. And I'll try to break that down a little bit more. So when we talk about access, you can think of some of the examples that we heard today, which were For example, we heard about Rology and Mama Ope and Pathology Network. These are all services that we just don't have enough pathologists or radiologists in most of these contexts. And so when we embed AI into our processes, we can provide much better quality care at those access points. When we think about like beyond the access and quality bit, like the thing that we're thinking a lot about is we actually started off around the same time as the LLM wave really hit, and the hype really was there. But if you look at the trajectory of large language models and generative AI, the quality of clinical decision making these new AI models are able to do is quite phenomenal. I was just talking to you this morning that there was a paper very recently that showed that AI without a doctor was actually better than AI with a doctor, right? So the AI without a doctor was at 92% accuracy, whereas the doctor with the AI was only at 77%. So the doctor is actually bringing down the accuracy of the AI, not the other way around. So if you really extrapolate that forward, you actually arrive at an era where you have unlimited clinical intelligence. And when you have unlimited clinical intelligence, that actually changes the entire premise of public health, because we've designed public health because we did not have enough clinicians to go everywhere. But if you have like a clinically intelligent agent at every single rural outpost in Kenya, in Bangladesh, in India, then public health starts to look very, very different. We also looked at an example of the generative AI-based personal chatbot. So you now can have like almost a doctor in your pocket, a counselor in your pocket, like very, very within the next few years. And these tools will become more and more voice enabled in your local language and local dialect. So that also becomes like a huge kind of like equalizer in terms of democratizing access to these kinds of technologies. So we are thinking a lot about those aspects, those disruptive aspects of AI. And then the final piece that I'll talk about is the plumbing and infrastructure, because oftentimes we think about all of the shiny new objects, but we don't think about what it would take for those kind of tools to get to scale. So things like data interoperability, such a huge part of enabling an AI to kind of reach the last mile. Things like benchmarking and validation, like how do you actually benchmark models in very different use cases in very different contexts. We don't have enough benchmarking data sets right now, right? So thinking about language localization and dialect understanding, like voice enablement in local languages, like all of those different aspects of AI that many people are not really focused on. And those are stuff that we're thinking about as well.
Yeah, and I love to hear that some of the challenges you're facing goes back to the basics of data interoperability and how we can validate that, which it kind of resonates a lot with the work Joy was talking about. But I want to turn that around, because you were talking a lot about large language models and how that big paradigm shift came with this part of the AI world. But before large language models, we were all trying to figure out what is the best AI to find patterns in image, patterns in data. And we kind of shift from that. And so there's going to be shifts around. So I want to bring Jim to the conversation. And basically, what I've heard about is that you have a very unique perspective on this, because earlier on, you've been in the front line of the cell phone revolution that happened at the time, and currently serving in dozens of tech companies' leadership. What is your take on this revolution? Where are we going? What are the challenges forward in AI?
Well, I'll cover two topics.
Okay.
The technology and then the people. So on the technology side, actually, cellular offers a very interesting lesson about AI. We are just scratching the surface. I'll tell you a quick story. 1989, the largest telecommunications company in the world, AT&T, hired the largest consulting firm in the world, McKinsey, to study this new technology that had been developed over the past 10 years, which the Federal Communications Commission was about to license. And they asked McKinsey, how big would the market be? So McKinsey in 1989 said, by the year 2000, there'll be 100,000 users of cell phones in the United States. That number by 1999 was 1 million. 3 years later, it was 10 million. They were off by a factor of 1,000 to 1. Why? Because they didn't foresee that Qualcomm was going to invent a chip that could take the radio spectrum and divide it by 10. They didn't see that there was going to be a new generation of alkaline batteries that were half the size and twice the longevity. They didn't foresee that Intel was going to come out with a new generation of chip. There were all kinds of things that happened in that 10-year period that were completely unforeseeable to McKinsey. And the kinds of things that Rubayat is talking about investing in are going to be the things that we can't see. We won't see them now. But I, for one, believe that AI is going to be the single most transformative thing in this first half century. There's nothing compares to the change that we're going to see in the next decade and a half. It's a great area for investment, speaking as a venture capitalist, but also a one that we got to be careful because on the delivery side in particular, the amount of capital required to build the infrastructure is beyond most any normal sources of capital, except maybe sovereign wealth funds. But the second thing is people. And Joy, Moka, Wilfred, that's what we need more than anything else. This is a conference about innovation. We need people like them. So the other thing that we do is we have this organization, the Presidential Precinct, and our job is to find young leaders between the ages of 25 and 35 around the world who have already demonstrated leadership ability and give them tools, help train them, and help them be better innovators. We'll cover almost any topic, not necessarily healthcare, although we've had a lot of healthcare people through our program. But as important as AI is, what is impossible it's impossible to have progress without the people who are going to look at AI and say, I bet I could do this. And those kind of innovators are not going to be generated by any technology. They are people, and they have to be encouraged. And that's what we try and do at the precinct. I think that's what you're trying to do, Krishna. And I applaud Duke and this whole organization for trying to promote innovation, because that we need these people to combine with that AI to make it realize that kind of exponential growth we're going to see in the next decade.
So we're talking about people. We're talking about the need to foster these innovations. And what I see in a little bit of my experience at Duke is that most of the AI programs, they fail at the implementation phase, either because they're not answering a specific question or because they're not take up on for some reason. So I kind of want to pull this question to the panel, and I'll let you open to answer, but I'll invite some answers first. And the first part of this answer is, what makes an AI company or someone who is coming up as an AI investigator or as an AI entrepreneur investable? What are you looking at when you're thinking about who is the people I want to invest in?
Well, speaking as a venture capitalist, I'm looking for leverage. I'm looking for, can we invest $1 and produce 10? If this is about investing $1 to produce $1.50, venture capitalists aren't interested. I mean, you may get government interested, you may get nonprofit funders interested, but you won't get private capital interested unless there's a tremendous amount of leverage. In our portfolio, I mean, my investing career over the past 40 or 50 years, I mean, 8 out of 10 things we've done, we failed. I mean, they look like great ideas, they look like good entrepreneurs, but they failed. Sometimes through no fault of their own. Sometimes somebody just invented a better mousetrap before they got their mousetrap to market. So if I'm going to invest in something, I need to see something that has huge leverage. And so if I were a researcher developing something, I would be looking for those kinds of things where I'm going to get the kinds of returns it sounds like Wilfred may be getting from some of the things he's doing. It's kind of returns that Moka's getting from some of the things he's doing.
So what are the gaps that you think as the entrepreneurs building this out? What are the barriers in getting it to be to give you this leverage? What are the barriers you faced in building your own companies or building your own the examples you showed to get to a point where you were investable, that you were drawing that attention?
Let me kind of take a leap of faith here. Well, there's a lot. Healthcare by itself is a complex industry compared to, let's say, food and beverage, real estate, shoes, clothing. Healthcare is a product that the consumer doesn't even, many times they don't know what they're paying for. They don't even know what is good for them. It's segmented into labs, pharmacy, service provision. And as you scale, you are likely to have an increased overhead by virtue of the fact that you need a larger labor force to scale. And that's really why AI is exciting, because for once now we have the opportunity to scale without an increased labor force, right? And so literally we, in our model, we have been able to use AI and increase the productivity per doctor from 20 patients a day per doctor, and now we're pushing 50, 60, right? Because they are using AI to write visit summaries, follow-up appointments, medication reconciliation in seconds, which before AI took them a lot of time. So the first thing is healthcare as a sector is very disintegrated. And as a venture, you kind of have to really figure out what it is how to bring those pieces together. The second thing is that many of us as entrepreneurs in healthcare, we come from a needs-based perspective. What is the need? And so we really obsess about the need. Now, and I think it's proven that because there is a need doesn't mean there's a business, right? And so it's easy to create a mousetrap for a need, and there's nobody willing to buy. So having an app that tells somebody about their next visit, how much are they willing to pay for that information, is God knows. But I think we've seen many of those who run out of, it's a great idea from a grant perspective, but there's just no market for that. So we really need to have, I would say, programs, and that's why I think the work that Innovations Healthcare is doing is critical, is that it requires a conscious approach to market and a very clear problem you're solving that has commercial potential, without which it's a very good need that you're solving. And you could do research on it and go for research grants, which many entrepreneurs don't have the background to go for research grants. So they are forced to depend on, really, they have no strategy for scaling beyond the first seed fund they get. And that's, I think, the trap that many founders find themselves in.
Any thoughts? Yes, please.
Yeah. Yeah, just to agree with Moka that it has to make business sense, right? And for us as an investor, we're always looking at that business traction, like how many customers, repeatable customers, are willing to spend whatever amount they're spending, and they are happy to spend it, right? And they are telling other people, there's also a multiplier effect. They are telling other people how incredible that service is. If it's a telemedicine platform, that it saved them their, the time they would have queued in the line or taken a 100-kilometer journey, and they're sharing that experience in a way that will bring more other people to use the product or service. We also look at yesterday I talked about the 3 T's, right? The team, right? If Moka is building CheckUps on his own and there's no other co-founder, then I get very worried as an investor to put money in him. But if I see a diverse team, co-founders with diverse background, tech, healthcare, business, that's around the team, right? Then how coachable, mentorable are they? Because we are an incubator, we come in early, so we're going to be giving a lot of advice, and we want to see how open are they to differing opinions, to mentorship, to coaching, to pivoting. The other thing we look at is the soundness of the technology, and in this case, it's something we call the product, the problem technology fit, right? Are you having the right technology for the right problem, or is technology just an add-on? We don't like to see people who start with technology first. I would rather people who started with just the problem first and technology came later on, right? So I'm very wary of people who just flaunt at the very beginning that I'm an AI company and they just want to go down that tech first approach, as opposed to telling me that I'm helping NCD patients in Africa or in this place to easily access medicines, and this is how I'm using AI to do that, right? So that's the technology part. Then the third one is I talked about team, technology, and traction. So traction can be either, if you're doing something that is very scientific, like very inventive, traction could be in terms of evidence, the body of evidence you're generating. But if you're doing telemedicine or the more tried and tested kind of applications, then traction would mean customers and how they are growing. How are you growing every day? You know, month on month, year on year. That kind of traction. So when we look at those three things, that's how we're able to come to a conclusion to invest. But most importantly is social impact. We wouldn't invest in anything that is not going to help the low-income population as we grow, right? Other venture capitalists are okay investing in things that are, you know, mid-market and things like that. But for us, we're very clear that you need to be serving the people who really need that access. Yeah.
Very McKinsey-like framework, the 3 Ts. So completely agree with everything Wilfred said. I just add that, just reiterate that it's really important for entrepreneurs to start from the problem, as Wilfred was mentioning. And sometimes that would mean going the for-profit route, which is perfectly understandable. Like if there's a pathway to scaling the business in a for-profit approach, absolutely. But there's also a lot of nonprofit social entrepreneurs who are addressing problems, but they're trying to find another means to scale. Sometimes that means working with governments. So as a funder, when we look at a nonprofit and try to evaluate them, we also look at the same leverage, but from the perspective of impact, and say, does $10 that we invest in this create $100 worth of impact in the long run? And do they have a clear pathway to get to that kind of scale, right? Whether that means building the right evidence at the right time, whether that means having the right partnerships in place, whether that means having academic partners involved. So there can be a lot of different pieces to that, but it's really, really important. And then the last piece that I'll mention is also kind of building on the team front. I think it's really important for the team to be extremely resilient, because in most of these markets, they're often faced against impossible odds. Even as they're building on AI technologies, like they don't have the right talent, for example, often in these markets, right? They might, like the same, a Kenyan or a Nigerian organization might be paying 3 times more for the tokens that for a large language model than someone sitting in Silicon Valley. So there are all of these challenges that are stacked up on top of each other. And unless you're extremely resilient, it's really hard to overcome those challenges.
By tokens, you mean like if you want to use the model, you have
models,
to pay the company that you're using the model for, so it costs more. Yeah, that makes a lot of sense. You want to make a comment, Joy?
Oh, sure. I was just going to piggyback. I mean, I agree on the points, but I wanted to highlight, especially with AI and the new model, everything coming out, right? It's overwhelming and impressive at the same time. But I can't tell you how many times I've sat in a tech meeting with our team and said, yeah, that's neat, but not necessary. We're not doing that. So I think it's really easy to want to integrate a technology tool, hoping that this will solve my problem. But I think you've got to stay core to what is the use case that we need to solve for and not deviate from that. I think the solution becomes a lot easier, right? You're not integrating cute avatars when you've got to figure out if someone needs an HIV kit delivered or a phlebotomist to their house. So it's like really centers around what workflow you're focusing on. And I think that will help later on. I think some of the companies that you've seen that probably have been funded $1 gajillion, but have had not much commercial value yet, probably don't understand that the incentives are so complex in healthcare. Like Moka was saying, patients aren't often the people who are paying for it. It's the payers or, you know, a government system or things like that. So just to make sure those incentives are aligned as well, and you're working towards that.
Great, thank you. Jim?
To tie together several points that were just made here, if I look at it as an investor and look at the nature of AI right today, what we see being built right now are gigantic freightliners. They're giant bombers. And the best investments, I think, in the next 3 or 4 years are going to be the people that build the drones. Can you take AI and scale it down?
Mhm.
Can you take it so you do not need a lot of tokens, so that you have tools that are very easily deployable with minimal hardware and minimal connectivity? And right now, all the focus, all the new money going into OpenAI at $165 billion valuation today, that is not scalable. That's not something that's going to help solve health problems in the developing world. So to solve those problems, we need people that can scale it down.
Makes sense.
Can I just add
Yeah,
one?
I want to
point
open
that?
to the room, but please,
Yeah.
please.
So just to build on Jim's point, I think people really underestimate the power of user experience design. So when you are building on a foundational technology like AI, it's often easy to get seduced into trying to fund the large foundation models and the open AIs of the world. But then someone who's actually building the interface on top of that API and creating an interface based on really deep customer insights that they have in their own market. Like, I don't think someone from Bangladesh like me could go into Kenya and build the right interface for that market, right? So really local entrepreneurs with local customer insight, building those interfaces, building those user experiences around the technology, I think that's going to be the next market.
I love this. I want to open questions from the audience, questions from online for a few minutes. I do want to ask a final question, but I love this idea that we're talking about AI, but we're talking about the challenges in bringing AI to reality go through implementation, go through thinking about the problem, thinking about the small scale, thinking about the products that are locally driven and not the next OpenAI or the next big LLM, which I really like that part of the conversation. There's a question there. We have microphones to get over there.
That microphone that's
Yes.
up here. This one.
I'm absolutely shocked. Somewhere again from Afia Research. 8 out of every 10 enterprises failed. Have you considered using AI to narrow that? Yeah, so you'll wish that gets better. But the other question for you is, in Silicon Valley, you see lots of money thrown in at entities that take years to break even or even make profit. But it looks like the demand here is pretty, the demand for results here is pretty aggressive to want to have or expect very quick returns out of an investment in something that is still not clear in that space.
So two questions there. I'll try and answer them both quickly. You could use OpenAI, but it's never going to predict the founder who gets a divorce. It's just there are all kinds of human factors. There are all sorts of market factors that you cannot predict what's going to happen with your competition, that sort of thing. I'm sorry. The second question was.
So how do you expect, how do you deal with the fact that there's not going to be a fast return of investment in this when you need a lot of money to put in to develop this?
Yeah. There is a place, and I'm not gonna directly answer your question, but there is a place for AI that we talked a little bit about last night, Krishna, which is in pharmaceuticals, in drug discovery. As an investor in that field, and I've got half a dozen pharmaceutical investments under my belt, and they are agony. They are absolute agony. We have a small public company called Acumen, which has an Alzheimer's drug. I first invested in that 14 years ago. We're going to have phase 2 clinical trial results at the end of 2025. If it works, it's a $1 billion drug. It's going to help just so many people. It's going to be one of the life-changing for the entire world. And if it doesn't work, I've lost millions of dollars. And there is no way to predict that right now. What AI can do, and we have an investment in another company where we're looking at right now, it's going to have a cure for macular degeneration. Looks very likely. They discovered the molecule effectively using AI. They essentially took anonymized databases of over 3 million patients and looked for correlations between macular degeneration and what? And they discovered, I said this last night, they discovered that AIDS patients didn't get macular degeneration. And they traced it to antiretroviral drugs. And that is AI in a nutshell. And if we put AI to work doing that, one of those long delays that you're referring to could actually be greatly truncated. And I think it's one of the areas of greatest promise that I see in the next 5-10 years.
That's great. Does anybody want to comment?
Yes, just one comment on the second question. Having been an entrepreneur and done this, I can confidently say that some of the Silicon Valley conventional wisdom, like fail fast and blitzscale, things like that just don't work in healthcare and in emerging markets. So when you're trying to like raise your way to scale and profitability, it's never going to work. If you try to fail fast in healthcare, that's going to burn you crazy, right? So you just have to make sure like you're patient, really focused on the fundamentals and basics, and slowly kind of build customer traction, trust, and equity in the ecosystem. Like there's no shortcut to that.
I would double down on that. Some of the best investments we've ever made were investments that looked like they were failing. And we were patient. And we kept pushing, we kept iterating till we got it right.
Hi, thank you. My name is Tiff Jang. I'm a Master's of Public Policy student at Yale. I would admittedly consider myself like a AI hesitancy person. And I think one of the reasons is that there's definitely a lot of potential or opportunity for AI to exacerbate inequalities as well, especially thinking about the data that we do and the data that we don't have. So I'm curious if you could speak a little bit about what sort of guardrails have you seen popping up to prevent this, and or what would be the idealistic ones that you would want to institute? Thank you.
Well, good luck with answering that.
I can go for this. Not really from a guardrails perspective, but to just think of one way we can have a level playing ground. I feel like right now, Africa and other developing countries, we are what we call data deserts, right? We are not generating any data at all compared to. I just did a 9-month data science AI course last year and doing it from Nairobi, but I kept using data sets from US cancer registry, UK kind of data, UK trauma images. So you find that there is no enough data we are generating in Africa and other developing worlds. And I think in the global south, the only person who is doing a good job at data generation is China. But most of the other countries compared to global north, we're not generating enough. And that's what might lead to one of the concerns you have of that inequality. If the same thing we found with pharma, the inequality in pharma in terms of inclusion, exclusion of minority and different backgrounds, just because they are not in the target group for the clinical trials. The same is being repeated now with the AI. If we have a lot of data sets coming from one region or some regions, and we don't have enough data from this, so that means that the models inherently will have a certain bias, right? For lack of a better word. So I think what we can do as African and developing world countries is make sure we are also generating our own data, right? And we are putting that data, aggregating it in large enough data sets that can be able to now have an impact on the kind of models that are coming out. I'll pause there and let others comment on the same.
I'll piggyback on that a little bit. So I had a similar concern as we started scaling and integrating more AI and informatics work into what we do. And I think part of the exercise here is acknowledging that you're going to look at the data with some humility. You're going to accept that it's going to be inaccurately charted a lot. I mean, you probably have all seen your medical notes and looked at and found an inaccuracy of some sort, right? So there's a degree of accuracy and inaccuracy you must accept and approach it with some humility. I think the other exercise is elevating or making the data more, in order to make these models more equitable, we've got to collect more and more data on different populations. I mean, look at the drugs that are being made where women were excluded from the trials or minorities were excluded from the trials. So I think there's got to be a big push in collecting more and more data from diverse populations and then acknowledging, okay, maybe the models we have today are kind of accurate, and then integrating it more and accepting that and controlling for that as much as you can.
Just add just the notion of inequities and AI is really one that is very core to what should AI do, right? Now in healthcare, we have dependent on national governments creating large data collections to create a common national policy around how you should treat hypertension guidelines and stuff like that, right? That is where we're coming from. With AI, it has to be personalized, right? That means the healthcare system now has to quickly pivot from one of national trend to individual solutions, right? Now, in the case of chronic diseases, what we learned very quickly was that to be effective at predicting and guide and using AI, we need to have lipid profile data, total cholesterol, LDL levels, HDL levels, ECG data on patients. Now, if the primary healthcare system is not collecting that data, then how do we create structures to get that data, right? Even for the work we're doing with urinary upper respiratory tract infections, when we've modeled, the biggest predictor of whether it's a bacterial versus a viral infection is procalcitonin levels. Now, 95% of the healthcare facilities in Kenya do not do the procalcitonin test. So now how do we create a system whereby we're able to afford and allow procalcitonin to be measured in the population to allow a model to work, right? So it really requires a very deliberate effort in what are you investing in? And it cannot be, there's no you can't really have like a salami approach. You really have to choose, in this case, upper respiratory tract infections and build the supply chain to help collect that data, right? That's what we've learned at this early stage. It has to be personalized and you have to collect way more data than is available in most primary care settings for it to work.
Jim?
Let me summarize what I think Moka just said. AI is the solution to the inequalities. You're talking about a snapshot in 2024, and the databases are very unequal. There's the amount of data that is available in the developed world versus the undeveloped world. But if you talk about what Joy is doing, what Moka's doing, 3 or 4 years ago, they had none of this data on their patients. And now they're building a lot of it. And if I look forward 5 years, the data that's going to be available to the world is going to be an entirely different set of data. And I think those inequalities will disappear.
Can I just add another thing? So another way to mitigate like some of the inaccuracies, I think part of the step is also involving the end user, the patients, right? To double check for accuracy. Often in medicine, we say, did you ask the patient? We can sit and analyze data all day long, but it could be totally inaccurate and irrelevant for the patient. So I think part of it is involving them in part of the process of building as well. Like we've seen this when we train our own models where we've found that we have incomplete data because the patient is telling us, oh no, I saw someone else here as well. And then our models get better once we incorporate their feedback. So I think it's important to involve patients as part of the process as you're building, just because that feedback's so invaluable.
Yeah. One last question.
Don Goldman, Duke, Harvard Institute for Healthcare Improvement. So this is great about the promise of potential. And obviously you talked about as one theme, increased productivity, taking work away and becoming, but there was a red flag there I would like you to respond to if you can, or if you're willing to. You mentioned, I think, that the number of patients that could be seen went from whatever to 2 or 3 times what it was, 50 or some number like that, I think you offered. You're talking about trust and relationships where the patient is your partner in care. Some of us who know primary care well in various parts of the world hope that AI would provide more time to build a relationship and talk about what's mattered. To the health systems that are paying for this, productivity means more patients per minute. And so I wonder how you're going to balance those challenges and have AI reach its full potential, which is not just efficiency and productivity, but quality of care. Thank you.
Good. So what we see is that with AI and the tools we have now, we can engage a patient for 90 days with minimum in-person interaction, right? So literally, did you like your visit summary? Yes. Do you need your medication refill? Yes. What are any of your symptoms? And all of that is happening through a chat on WhatsApp, right? So the tool allows us to create a lot of personalization without necessarily adding on the burden of the clinical worker, right? And so the early trends, again, I mean, we're still learning, right? We're still in learning mode, but the early trend shows that patients do not want to spend a lot of time in the clinic. That they have said, because you lose more money in the waiting room than you're going about your business, right? So if you can keep you at home, keep you around your business and attending to your needs, delivering medication, speaking to you on demand via WhatsApp, then you get a good satisfaction. And so far for our patients, we're getting really 96% satisfaction just based on their post-visit satisfaction scores.
Yeah, Rubayat.
So just thinking back to my last like primary care provider visit, it was a 15-minute encounter, and of that, 13 minutes were spent in him looking at the screen and filling out forms, right? So that's what the typical primary care interaction looks like, even in many places of the world where the community health workers or like paramedics are providing that first line of primary care. They're increasingly burdened with busy work. They have a lot of forms to fill out. They have paper forms. They have oftentimes duplicate digital forms as well. So I think the real promise of AI is to take some of that busy work out. So if the forms can be filled out with kind of an ambient AI that listens to the conversation and just fills out the forms on its own, I'm starting to see some innovations in that, even that operates locally on the phone without internet connection. So I think that's the real promise, and it doesn't necessarily need to be a physician in all places, right? Like ultimately the main connection you have with your health system is with a personal relationship with your primary care provider, and the primary care provider in many places is the community health worker. So if you can really enable them to have meaningful connections with the patients and take the busy work out, I think we'll be in a much better place.
Well, this is a very interesting topic. I'm sure we can keep talking about AI forever. So please engage with our panelists at break. I want to thank you all. This was a very good conversation. Thanks, everybody.